Any questions for the, I know we just spoke about liabilities, but any questions for any of the, speakers? Yes.
The fact that HC marijuana is a Schedule 1 limit research.
Can you please press the microphone? Yeah. Power, hold.
Not working.
Is working now.
Does the fact that marijuana is a Schedule 1 drug limit research?
Who would like to take that question?
I will. Yes. Yes, the University of Mississippi has a license from the DEA to conduct research on cannabis. Historically, they were the only university that was allowed to do it. The DEA announced that they would give out 15 more across the US recently, and we're kind of just waiting to see who gets those so that there can be more research done. There's a lot of research done internationally and in Europe, but of course here that's not really helpful for physicians.
That's also why the MMCRA was passed. It was to allow increased access to research grade THC. They found that that was the holding block, which that's why only one place was allowed previously. But it's a brand new law, less than 1 year old, and I'm not sure that anyone has even gone through with that.
And very quickly, the 2022, I don't want to mispronounce it, Medical Marijuana and Cannabidiol Research Expansion Act, that actually promotes further research for marijuana.
Any other questions? Go ahead, Tom.
So the inability to prescribe a specific dose of marijuana treatment due to federal regulations, is that a big hurdle for state like a lot of issues in dosage, the way that the medical law is set up? Is that a big part of it? Is because you're legally not allowed to pass those regulations?
Yes. Again, yes, but whenever Dr. Simicello was giving her presentation, I kind of grimaced at the fact that I was asking all the physicians in the room to help us with that dosage and communication with patients, and then she said, no, don't do that. So take her advice, because she's the professional and knows what she, knows the legal and the medical side. But it made me think, okay, so what do we do? Because we have so many patients in Oklahoma that have no idea what dosage to take, what type to take, how to take it. And there's just not an easy answer, because I know from a regulatory standpoint, we need physicians working with us and working with patients, but I don't know the easy answer to that.
Dr. Sandbar, are you on?
Just to go towards that dosage, like giving numbers is definitely like a prescription, but I would imagine you could probably say start with the lowest.
So are you suggesting don't have a complete prescription then, but just have some elements of it? Like
Recommendation would be good.
Okay, so right.
Go ahead, sir.
Sorry about that. No, we're here. Oh my goodness.
Yeah, I left because they don't.
Sandy, we can hear you. We can see you too, but can we project it? He's actually on camera now. Hang on a second. Let's get him on. He looks good. Okay, we have a lot of time, so this is good. There you go. Sandy, we can see you. We just lost audio from you though.
I think it was disabled because he was.
Oh, okay, good. All right, Dr. Sandbar, do you have any questions? We're in our last panel discussion with all the speakers here at the panel. Oh, he's on mute now. Now he's on mute. Oh, okay. You can.
Yes, can you hear me pretty good?
Yeah, now we can hear you.
All right.
Again, what a fabulous morning with all these wonderful speakers. And I apologize for the lighting. It's not the very best. So let's open it for discussion. And there was a lot that was said about product liability in the early part of the morning. So I hope there'll be a lot of questions and answers and comments. Thank you so much.
Thanks for joining us, Sandy. So the gentleman, I think, was asking a question. Yeah. Can you speak into microphone? Power, hold, speak. Yeah.
What is the rest of the world doing about marijuana? Just
Anyone want to take that question?
Have you heard of Amsterdam? That's a joking answer. I'm sorry. I don't know. So do you have any insight? There are research-based studies out there, medical studies out there from Europe and from Canada. But I couldn't tell you just overall what they're doing. It's a mix. Do you have anything?
Well, just to add to that, interestingly enough, Israel seems to be quite advanced in research regarding marijuana and medicinal uses. I don't have any specific information just that I can rattle off the top of my head. Just in my reviewing what's being done elsewhere, they appear to stand out in research for uses of marijuana.
In many Asian countries, the use of marijuana remains as a taboo. More so, the prescription of medical marijuana is not even in the picture. It's illegal.
And if I may add, there has been quite a bit done in Canada. Canada is also quite ahead and trying to catch up with Israel. Lee is very right that Israel is probably very prominent, but Canada is trying to catch up with it.
Okay, thanks. So, Dr. Franzak? Press power, hold, speak.
Oh, there we go. Yeah. Right.
Never allowed our doctors
To prescribe marijuana.
did do, however, was we issued a statement that
A particular disease or illness, which was recognized by the state to allow the use of marijuana. So we just basically certified that a patient had a particular disease, let's say like multiple sclerosis was one of those on the list. And then that entitled them to then go to a dispensary and get marijuana. We never really gave them any recommendations, as to how much they were to use. It was, I assumed it was up to them and the people at the dispensary. But now that we have ad lib clinic or dispensaries now where anybody can walk in and buy it, doesn't that just make the entire question moot? We don't need to have a physician to prescribe marijuana for anything.
Anyone like to respond to that, or Dr. Kelly?
Depends on the jurisdiction.
Yeah, so in the state of California, recreational marijuana is illegal, except that physicians can continue to recommend marijuana. You can't prescribe marijuana because that would be a violation of your DEA license, but you can recommend marijuana. The reason that it continues is because a person who has a recommendation can carry more marijuana on their person and can grow more marijuana plants in their home if they have a recommendation versus recreation.
We're going to shift to, we have a lot of time, so don't worry. We're going to shift to some online questions. Mary, please.
Okay, we have a question in regard to in Oklahoma, specifically the patient relationship, physician-patient relationship necessity when recommending. Do you want to take that?
I'm sorry, I didn't hear that.
So what type of patient-physician relationship there is in Oklahoma State when there's prescription, is that correct? Or recommendation?
when recommending.
You want me to do it? Okay. So the way that it was written in the state question that the people of Oklahoma voted into law, I just like to remind people that if you're from Oklahoma and you voted yes, that's, this is what happened. So it was very, very sparse, no qualifying conditions. The physician just has to be board certified in Oklahoma. There's a lot of telemedicine. I don't think that there are a lot of bona fide patient relationships, physician-patient relationships in Oklahoma when it comes to these recommendations. So the sparse nature of the law kind of kicked it off and exploded the number of patients quickly. So our medical program is different than others. In Illinois, there was a list of qualifying conditions, as the doctor stated, and most states with if not all states with medical programs, medical cannabis programs have qualifying conditions. We were not set up that way, and the legislature hasn't had the appetite to create qualifying conditions or create more stringent requirements around that patient physician relationship. And part of it is just the philosophy of how it was set up was kind of the most free market experiment in how to legalize the use intrastate for medical cannabis. And so we're living through this experiment basically together.
Mary, any more questions or? So next question.
Yes, I have one from Judge Burton again, and this was from this morning, but she asked, with respect to THC in the system, we've been told for years that we should give our chronic THC users 30 days to consistently test negative in treatment courts. But with the higher potency levels these days, should we be giving them more time? I don't know if any of you-
Pharmacokinetics, pharmacology, Dr.
yes,
Kelly.
Actually, I don't know if we know the exact answer to that. What we do know is that the more adipose tissue a person has, the longer they'll test positive. Whether certainly increased concentrations will mean that more will be taken up in the fatty tissues, but I don't know if we can make any definitive recommendations.
Any other comments? Okay, here, I think we have a question in the gray area from a family physician working at the VA. Is that correct? I thought your hand was raised. Yes. Can you press the button and speak to it?
So
Can you speak up a little bit, please? We can hear you.
I'm a primary care physician. Just want to add to the question. And if patient keep coming back positive after 3 months, we have to do more counseling with the patient to, and that we cannot keep prescribing opiate from the VA if they keep having their urine drug test positive for the marijuana.
So my understanding is that, for instance, in the VA, that is, let's say in a state where it's permissible to prescribe or recommend medical marijuana, and you have a contract, an opioid contract with the patient where it says or specifies that in order for the patient to be using the opioid or allowed to use the opioids, they are not allowed to use marijuana, and their urine drug screen test keeps coming up positive. What are the so in terms of physician liability, if you discontinue their opioids, is there liability? If you continue to have them on opioid, it's not liability. I think that's where is that where you're getting at?
Sorry, that was the question I asked earlier. And then one more question for the doctors who recommend patient can take marijuana for their underlying problem, PTSD or anxiety, whatever. So those doctors, do they check State Department record to make sure that the patient is not on opiate from any other provider? Because I have a lot of veterans, they say that, oh, I have a license to take marijuana from whatever pharmacy they get it. So they have the doctor prescription, or not the prescription, the recommendations. But I was wondering that, do they check their State Department record that the patient is getting opiate from VA?
No.
I don't think so.
Anyone want to address? I think there's
Yeah.
multiple part questions.
Well, maybe I can address the first one. So if I understand the question correctly, you're asking if somebody has been taking smoking marijuana and then they have to abstain because they now are on opioids. You're serially biologically testing their urine and it continues to come back positive. What do you do after 30 days or 45 days? Well, I would think that, now that we understand the pharmacokinetics of THC that builds up as they smoke it builds up in the fat tissue. And then once they stop, they'll start coming out, they'll continue to test positive. You may want to do a quantitative test. And over time, if you see that the THC continues to drop, then you can say, well, no, really, according to the pharmacokinetics, it's coming out of the fat tissue and they're not continuing to abuse marijuana. 30 days, 45 days, those are arbitrary time limits. It all depends on the patient's body habitus. And but if you can see that it's consistently coming down, you can be fairly confident that maybe they're not smoking.
We do the quantitative test too, and patient have the urine drug test showing that the level is going down after 3-4 months, and after like 6 months, patient has urine drug test positive, keep coming back again. So then I was asking my admin that what I'm supposed to do. Should I just abruptly stop opiate or or give more time to the patient? They say if you abruptly stop opiate, they will go through the withdrawal and they will have more patient complaints. So talk to the patient and make mutual decision. But that's the hardest part. Patient can never, they would never want to come off of the opiate, and also they keep using marijuana intermittently. So that is the biggest challenge in the VA system.
Yeah, I think these opioid contracts are very, very difficult. In my practice, we have these pain management physicians that handle that sort of thing, and they signed a contract up front that they won't abuse any other substances while they're on the opioids and whatever medications are being prescribed. But it can be very difficult when you're encounter a situation where they come back with a positive urine drug screen. What do? Discharge them from your practice and have them go through withdrawal? Certainly, say discharge them and having them find another pain management physician, it's very difficult. It can take up to 6 months. So I sympathize with your dilemma. There's no really any good answer to that.
Tony, if I may.
Yeah, Dr. Sandberg, go ahead.
Like to talk about that effect. A couple of months ago, in the Journal of the Oklahoma State Medical Association, an article of mine was published, which reviewed all the available systematic reviews on the effect of cannabis and really it's an extensive work that's done by other people. I think that Jason earlier today mentioned something about those articles, but this, what it comes out to, if I may answer the question slightly differently from my very good friend Rick, I think that what came out of that study, some of the studies, is that number one, if you use cannabinoids, there is a chance that you would have an effect on chronic pain, which is similar to Tylenol or aspirin. So it's a very, really small effect, but it is definite and it is clear. Number two, some reported on the use of both combination medications, and the reason for using that is primarily to reduce the amount of opioids that are used. And sure enough, according to those studies, and there aren't that many of them, but according to those studies, the use of cannabinoids, if you are using them on someone that is taking, say, a high dosage of opioids, and you want to reduce the chance of them dying from an overdose, or certainly it may not be as effective, the addition of cannabinoids is something that you would consider as a drug in addition to, say, other ibuprofen or Tylenol or what have you. So the approach that and I commend to you, I think the article is in the book that I compiled on cannabinoids and was given to you all. I think the article is there, but it is in Oklahoma State Medical. So now the one thing that I'd like to recommend to you is that follow the recommendations of the November 22 recommendations of the government CDC guidelines, where they tell you that if you don't use opioids until it's a very last resort. Now, if you're going to use, and then the other thing that is recommended is don't use opioids alone. These are recommendations by the CDC. So in answer to the, I think, excellent question by the lady, I would not be afraid of having the combination used as long as you use it for a purpose. If you are using it because a combination might reduce the amount of opioids that they might take and reduce the overdose, that's a decision that the physician will have to take. But don't be afraid of it. Combining the drug, I would look at it, if I may put it in proper perspective from liability issues, if someone does not use a drug that is less effective than opioids, before using opioids, there may be a problem with liability. Why did you not use this? Why did you not use that? And you went only to opioids. So I would, now we don't have any liability issues, but I assure you those will come up in the future. So my recommendation to you is that do not, 75% of the people in the United States have or are using cannabinoids of some sort. So chances are you are going to see positive results in the urine, no matter what you do. And in this case that you mentioned, where opioids, I do not appreciate the thinking of a contract for opioids means denying the use of other drugs that may be helpful. So that's the only time I rarely differ with my co-lecturer, Richard. I invite doctors to use combinations that are safe under supervision of the doctor, that would reduce the amount of opioids used, that would reduce the hazards of overdose and death. So, and I think that this is one way to look at these important drugs. Don't look at them as just aspirin only, Tylenol, cannabinoids, opioids. Try to combine them in the way that is recommended by the CDC, and be sure that you supervise very, very carefully. Thank you.
Yeah. Thank you, Dr. Sandra, for that's an excellent comment, because I think, for instance, I'm an oncologist, so I write a lot of opioid prescriptions. I've been doing this for 20 years, more than 20 years. Feel very comfortable with it, and mechanistically, I can't see why if you're doing it correctly clinically, just with any drug-drug interaction, why you can't have a combination of cannabinoids or THC with the opioids. But I think the question here also may have to do with legality. And I was wondering if Dr. Ciamicella would, with your experience in law and now a physician as well, with this gray area, and I suspect that, let's say in the VA setting, in a federal setting, in a state where it is legal, but perhaps the combination in an opioid and marijuana are not permissible, or not, or you can't have one with, you need to have one to the exclusion of the other, probably because it's based on legality, and whether that imputes liability if you were to ignore it.
So I see a couple things, and first is the pain contract, which is not legally a contract, but it's an agreement between the patient and the physician. And you stated that it's included in the agreement that the patient is not to use marijuana. So that's an issue there, because if you're not sticking with your agreement, then there's no bite to that agreement and you might as well just erase that. So if you were to do it, you should probably amend the agreement to not include that. And then the second thing is you're in the VA system, and the VA is obviously not following the MMCREA. They're following the VHA directive 1315, which I wasn't reading the whole thing in terms of opioid use, but I can surmise if you're not allowed to sign a certification or discuss it unless specifically requested, they might have something in there about prescribing opioids when you're using marijuana. So I can't give you the exact answer because I don't remember what the 9 pages says in terms of opioids, but I would look into the VHA directive 1315 and see if they mention anything in terms of that.
Now, we also have to mention that that when you have a patient that is going to have marijuana, you have a separate agreement from the opioids. So you really have 2 agreements. And I think that Dr. Elia, if I may call her, she is absolutely right. You don't want to have an agreement that limits drugs. Avoid it if you and don't put the marijuana in there if you want to use it in the future with the opioids. But you have to use it before opioids. And let me put it in perspective. So a patient comes to me and I give them various treatments with non-opioids first, but I do not give them marijuana. And I'm talking about CBD primarily. By the way, when I'm using treatment, it's CBD with minimal amounts of THC, not enough to cause a psychedelic play. Here, you are going to give them CBD, and to potentiate the effect of the CBD by THC, you use a very small amount of that, and you really need to be a learned person about how to use it without making people, without causing overdose and death. So here, in this regard, we can identify what is going to be used. So let me give you an example of a hypothetical malpractice case. A patient came to to me, and I gave them, I tried for pain, for chronic pain, and I tried all the appropriate drugs that I used, NSAID, and I used all kinds of treatments, but it was really severe, and I needed some more. And I do not use the narcotic, but I give them a narcotic, and the patient dies from overdose. I could be sued for failure to use a less hazardous substance like opioid, like marijuana, CBD, but because I did not use that, I may be sued for failure to use a drug that does not cause ever any deaths directly from the drug versus using a drug like opioids that has a lot of hazards. So I could be sued for failure to use. But then I want to talk about Tony's point is very important. In patients that we see, cancer patients and others that really need them, the doctors that are treating cancer pain and acute pain and other pains, they really get some benefits from the CBD primarily and some THC with it. And in recommending, for those of you that wish to recommend the drug use, please do not use THC. Start with CBD, start with the lowest dose of CBD and increase to maybe about 30 or so milligrams per day or 50. And then you may want to add a little bit of THC to it. So we want to follow recommendation like Adrian and Lee and would mention, we really want to be careful when we give the THC, but don't be afraid of using the CBD, which is non-psychedelic.
Thank you, Dr. Sandbar. So I think we have some more online questions lined up.
We do, and this is a clinical question. I didn't see or hear much mention of anxiety as an endpoint to any of the cannabis studies. I have significant difficulty with patients being very resistant to even discussing stopping the use of cannabis because they feel it's the only thing that helps their anxiety. They wanted to know if anyone has any thoughts regarding cannabis use and anxiety. Do you think it could be increasing more patients' anxiety? And any suggestions or thoughts on how to approach this with patients to help them understand why abstaining from cannabis may be of benefit for them?
So what I'd like to say is that, first of all, we'll open it for, certainly the speakers, but if anyone in the audience with experience, please chime in too.
Yeah, I think that the problem with using THC to treat anxiety is that for some people it works just fine. For other people, it actually makes them more anxious. And that has to do with how it binds to the receptors. It is just a shotgun approach where it's bind. Usually the endocannabinoids will act very locally right at the synaptic cleft. So if it wants to achieve some sort of modulating effect, it acts at one place, right? You smoke marijuana, that THC goes to every single receptor in the body. And then, you don't know what's going to happen. So yes, for some people, they'll become much more relaxed, more talkative, maybe a little drowsy. For other people, they become, much more anxious and paranoid. And how can you predict that? It's completely unpredictable. So I think in terms of anxiety, I don't think that's a very good drug at all. And if somebody's on it and it's working for them, certainly you'd want to make sure they don't take higher doses of it and maybe try and find some alternative.
So what would you tell them? They kind of asking, they understand that when they tell a patient, this is making you anxious and it's making it worse, then they become more anxious when they try and suggest that they get off of it or stop using or modulate it. So what would you say to this practitioner? What are they going to tell their patient?
Yeah, I mean, the thing is, we give the best advice that we can, but every patient is autonomous and can make decisions for themselves. We tell them what we think is best, but certainly being under the care of a psychiatrist may actually help so that they can tease out what the issues are and maybe find a more appropriate medication for them.
Yeah, what I'm hearing from Dr. Kelly is to consider, psychiatrists, psychologists, and then alternatives, it being that THC cannabinoids may not be the best for anxiety, indication wise is what I'm hearing. Next question.
Okay. Can someone discuss the use of marijuana in the adolescent individual?
I didn't hear that. I didn't hear that.
Anyone want to do that?
Miss, what was the
Sam,
question?
Dr. Sandbar, huh?
Dr. Sandbar, would you be willing to discuss the use of marijuana in an adolescence?
Yes, I'd be happy to. Thank you. In adolescence, I think it was mentioned yesterday very clearly that if the drug is used, cannabinoids, during the period when the brain is not mature, and that means the period until age 26, do not use those drugs. Please do not use those drugs. They're dangerous for this group. I think Adria can address that very well, and I would avoid that. It can cause psychosis, but more importantly, it can cause permanent changes in the synapses in the brain that would last a lifetime. So I would think in adolescence, unless it is absolutely necessary, you're talking about a patient with cancer and you're going to treat them, that's a different situation. But to give them, to recommend them at below age 26, I think that is a no-no as far as I'm concerned.
And Dr. Sandbar, do you mean specifically THC containing or CBD as well?
I beg your pardon?
Do you mean THC containing therapies, or are you okay with CBD for youth?
Both are a no-no. We avoid both.
Both are no? Okay.
And THC. Yes, both of them, because the CBD does act to some degree on the CB1. It acts like THC. The only difference is that it inhibits the THC and tries to regulate the effect of the THC. And the CBD attaches to the side of the receptor. It does not act like the THC directly on the CB1, but the CBD kind of tempers the psychedelic effects of THC. That's why they use the CBD first and then add the THC, and enough so that it does not cause the psychedelic effect. So that's really, but as far as young people, I think they should avoid cannabis no matter what it is, whether it's CBD, THC, or anything. I think that's dangerous. I think you mentioned that, Adriana, yesterday, if I may recall.
Yesterday, somebody definitely mentioned it, but I mentioned seeing that in Oklahoma, we've seen, we've heard a lot from school districts who see middle schoolers and high schoolers with vapes, often vape pens with marijuana or the hemp-derived cannabinoids. So we just have an uphill battle to keep them out of the youth's hands in Oklahoma. But there are also groups. The reason I asked about CBD is there are groups in Oklahoma that advocate for the use of CBD for children with seizure disorders or autism. There are a few different groups of parents that believe CBD use is beneficial for their children. So I'm not sure if they have, I'm not sure what the medical oversight is or if there's research on those things.
So, Dr. Franzak, our neurosurgeon, effects on the brain.
I have a question.
Oh, he has a question.
Quantify marijuana use in terms of dosing. We're talking about using marijuana 8%, 9%, but in terms of the total dose, 10 milligrams 3 times a day, that would suggest, or 3 gummies twice a day, or half a joint 4 times a day. How do we quantify? Because unless we can quantify, I don't think we can study it. And since nobody is manufacturing pills that have a certain number of milligrams, I imagine the drug company can't make marijuana pills because it's against federal law, correct?
Well, there is Marinol.
Yeah.
Marinol is synthetic THC, and that's legal.
If we wanted to study regular THC, nobody's going to make that pill, right? So we have no idea how to quantify this. We're all talking about side effects and this and that, but we really don't know. I mean, if you got a good quality marijuana, you can go crazy, or you can be getting some grass off the guy on the street corner and not even get high. I think that's the problem here. We need to quantify to be able to figure out how much of the dose we're getting. And then I think we can make more sense of things, but we run into this dichotomy between the Fed's telling us we can, but the state's telling us we can, and nobody in between is willing to, try to study this thing effectively, except you said Mississippi or somebody. I think if we can quantify it and standardize the dosages, we have to go somewhere else. Maybe the Mexican FCA can help us with figuring out regulation. But our entities are touch it, right? They're probably hands off if it's illegal. But unless we can resolve it somehow, somebody actually quantify it, we're just spinning our wheels.
Well, I think you have an excellent point, because we talk about concentration, right? So back in the day when we were teenagers, the concentration of THC in marijuana was 3, 4, 5%, and now they've bred it so that it's 30%. But you're right. I mean, that is only the concentration. What we need to know is something like milligrams per kilogram or micrograms per kilogram or whatever it might be, and then that would make it So getting back to the point that Sandy was making earlier, that maybe there is some benefit for people to be taking some derivative, either CBD or THC, but until we can actually measure. I mean, what do we say? Go down to your local pharmacist, dispensary and get a joint, but you don't know if that's 30%, 3%. Do you roll a big joint, a small joint? You're right. It needs to be quantified in a way that we can say you need to take 3 milligrams. And if it's too much, you can say, okay, let's back you down to 2 milligrams. But we're not in that position at all. We'll say, they'll buy something and we don't know it's 15% or 30%. Yeah.
Well, the other thing too is the route of administration. Okay, are you gonna shoot it up your nose? Are you gonna inhale it? Are you gonna inject it IV? I just recognize that's a new way to go with it, or to take it orally. If we standardize the dosage schedule, instead of inhaling it, to put it in a pill form, so that we can then have a constant intake or uptake, whatever. Then we can begin to study it, but all of these different ways of taking it, if it's a short acting thing, you have to quantify it and then probably also standardize the route of administration.
So do we have time for me to comment?
Yeah, we have time. Go ahead.
With regard to what we call in Oklahoma medical marijuana products, think in terms of, everybody's probably heard of gummies. But candies, lozenges, there are lozenges that are prepared and sold now. And as I mentioned earlier, those have to be packaged with how much THC is in each serving. So that's addressing that point. What we don't have is a correlation between this amount of THC produces this amount of effect. So at that point, it's a little bit hard to dose. But what you would end up doing, as everybody said, start low and then get to the point you want to. Can't really do that directly with flower, which is the predominant way that marijuana is consumed. You actually could if you knew all the parameters that went into it. Because in essence, to create the percentage, you have to know the actual mass of what you tested, what you entered into test, and then out of that, how much of that mass was actually THC. So the whole testing process gives you that information. That in turn is then converted to a percentage. So you would have to know how much actual mass of THC is in this joint, and then calculate back from that how much actual THC would I ingest. So we would need to do something similar to that if the medicinal delivery was via smoking marijuana. That information is actually on a certificate of analysis now for somebody to actually go and look and see what that is. Whether anybody does it or not, I really don't know. And then we come back to the other problem, which I babbled too much about before I got to this. The fact that the value of that product now exists on the highest THC possible. And so the customer demanding, I want this to be labeled as high as it possibly can be, which it may not really be that. There's a lot of ways to manipulate that result so that it appears higher than it is. That's where we are trying to squeeze that down so that you can believe that what's on that label is really there. That's also kind of the problem that you have with research in terms of researching, particularly on marijuana flower. Regardless of whether somebody is manipulating the results or not, the variability that exists within one single marijuana plant does not really give you that precision that probably you need for actual research on that particular problem. For instance, it's kind of the rule of thumb. Within a regular normal marijuana plant grown under normal conditions, you may have as much as a 15 to 20% difference between one flower bud and another on that one plant.
Hmm.
So what happens is when somebody creates their batch, they pull all that together, pull out, there's sampling schemes, but you pull out different portions of that batch, mix that all together. So what actually is on a label is kind of the average of what's in that actual batch. But it may not be, it may be sold in different pieces and you may not get exactly that. Yes, sir.
I was thinking of is not to be using leaves and seeds, but to extract THC as a chemical compound, pure THC, and then using that in tablet or whatever kind of form.
Yeah, medicinal.
You know, now we've got extended release. So if you've got chronic pain patients, you can give them an extended release, but not to be dealing with the, like I say, the stems and seeds, but to use the pure THC to put that in a pill, quantitate it, figure out what dosage curves, LD50s, all of those things, and then do it that way. Because right now we, you know, whether the plants that George makes are better than the plants that Bill makes.
Right.
We're never going to get anywhere with that. We need to extract that drug, put it in a dose and give it to people and test it.
Yeah.
I'll give you a little perspective just based on what I know is going on in the United States right now. There are new programs where students are learning. There's, for example, a master's degree in cannabis therapeutics at University of Maryland, Baltimore. Someone who works for us at OMA has that degree. And so there are these young people coming up who are thinking like you're thinking. These things are coming. The innovation is there. It's just somebody putting it together. People are studying the endocannabinoid system more than ever to understand how much of what you're talking about, perhaps a concentrate, is needed to attack. I'm not a doctor, to work with the specific receptors. So I believe the research is happening. I think that people are out there in the US doing this right now, and you guys might know more than I do. So I think it's coming, but it's way overdue. It's long overdue.
Okay, thank you.
Maybe,
last,
maybe to put a nice label on it, put in there the use of artificial intelligence with marijuana. And now everybody will be reading about it.
and thank you, Dr. Franzak, for your comments. Point well taken. Last question from the audience here, Dr. McDowell.
Tony, I have a question, please.
Can we let Dr. McDowell speak first? She's been raising her hand, Sandy. Give us 1 minute.
Can't see that.
Yeah.
Just quickly, I mean, I think it's been such an interesting meeting and discussion, and just thank everyone for all of this. And having not been familiar at all with the situation here in Oklahoma, it's just been so enlightening to me and disturbing, I will say. But, you know, I am reminded of the phrase, ready, fire, aim. And it seems to me that's what's happening with this, and also reminded of the tobacco industry and the huge price we have paid and are still paying from letting commercial corporate folks lead us down the garden path, and then find out that neither the patients who were being, you know, kind of prescribed cigarettes by pictures of doctors on magazines, and doctors who are, we heard a tiny bit about the learned intermediary role that doctors play in this, which is to me a very, very important one. But neither patients nor doctors nor the providers, the growers, the distributors, we're all ignorant of what we're doing, and human beings are suffering harm. My question is the legislature here in Oklahoma and everywhere receiving the evidence that we have all been talking about this entire weekend, so that someone is going to say, hold on, we have to do our protective role of our constituents and act here, because people are just making this up as they go along, and it's very bad for everyone concerned, it seems to me.
Oh man, absolutely. You are preaching my message. So the legislature in Oklahoma has been slow in getting on board with adding more to the law around our medical cannabis program. Last year was a year that they did add more regulations, but what they're focused on right now is so much on the enforcement side because our licensing was so relaxed. We have far too much marijuana product in Oklahoma, and the supply demand is imbalanced. So the legislature has been laser focused on enforcement and not as willing to listen to the stories about how much we need beefed up regulation on the patient side, the patient safety side, the education side. So it's just a matter of getting to the right legislators who have the right power to actually do things, get things done.
And the research that's needed, obviously, this all has to be researched scientifically because folks are not, this is not informed consent. Well, none of us are informed about the risks involved and the benefits. Obviously, they're both.
Well, I hope that this next legislative session in Oklahoma specifically, we see much more of the conversation around that. Last year it started, but the community that helped get our law passed here is very loud and persuasive, and they just invade on the Capitol. So there has to be the balance of the other side saying, no, we're not, this isn't reefer madness. We just know that there's some guardrails needed, and it just has to be a balanced conversation. There's a book by Dr. Peter Grinspoon called Seeing Through the Smoke. If any of you haven't read it, he's a doctor that specializes in cannabis. Do you guys know him? No. Okay. So I read his book and it was perfect because it talks about how, I'm sorry, I'll wrap up in a minute, Tony, sorry. It talks about how in cannabis, there are the people who will tell you that it's perfect, it's God's plant, and there's nothing it could ever do wrong. And then there's the other side who says it's illegal, it's bad, don't do it. And we live in this world with cannabis every day of these two extremes. And we're very slowly moving to the middle where we're like, okay, no, it's legal in most states. We have got to research it. We have got to regulate it properly, but it's taking so long to get to the middle because people are staying on these really entrenched on their two sides.
So we're at the last 8 minutes of a conference, but I can't help but to see that we still have 44 participants online. So that's pretty amazing. So Dr. Sandberg, go ahead. You were going to say something.
Thank you, Tony. This is also addressed to primarily the director of Oklahoma Medical Marijuana Authority, as Adria. My question is, well, before the question, in November of 2023. The Consolidation Appropriation Act, Consolidated Appropriation Act was signed, and in June of this year it became effective, which affects all doctors who have, all individuals who have an DEA license. People now, as of June, all physicians, before they can renew the DEA license, they must take 8 hours of education in opioid, not 1 like we had before, and that's mandatory. And my question to the director is, are you planning, or what do you think about having a course for physicians? This is the first time we have a course to try and educate people about about the marijuana primarily. So what do you think should be done? And address it to both Lee and the director. What do you think should be done to educate the physicians, and should there be mandatory education?
Yes, I'll make a quick answer and then give it to Lee, but we have been on the path of creating CMEs. Getting them signed off by the OSMA is obviously, a hurdle, but I think we'll get there. We've been having the conversation. The legislature last year, there was a bill that was going to require cannabis CMEs for physicians in Oklahoma, and it didn't make it past the finish line, or it was vetoed. I don't remember, but that we are working independently within OMMA to work with physicians that will work with us to help us create this education portion for medical professionals.
Excuse me. Yes, that's the case, and in fact, the OMMA employee that Adrian mentioned a little bit ago with the masters in marijuana, will be working with me directly. And one of the things that we will, I've been kind of sticking my toe in that realm for a little bit now, but one of the things she and I will do together, start to put that together and come up with a more formal program. Fortunately, there are other people that are looking at this issue as well. I don't know if any of y'all are familiar with the organization ASTM, the Association of Standards and Standard Testing and Measurement, has come up with a guideline for what the body of knowledge for clinicians should be educated in. So we'll use that as our model. So we don't have to think it up or dream it up. We've already got kind of a roadmap we can go. We just have to be able to fill in the content. And so we're going to be, that's the direction we're going to be taking. So we should see some progress next year when we're together at this time. Hopefully that's a fully operational program.
And as the meeting conference comes to a close, since we have Dr. Sandbar, online and on candid camera, Dr. Sandbar, would you like to have the honor of making the closing comments and remarks?
Well, this has been an exceptionally excellent performance by all the speakers. I'm so grateful to each and every one of them, and I hope to be in contact with them as well. I want to congratulate them for taking the time to, this is given freely, and people are not getting any remuneration for this or paid any money. They're doing it out of the goodness of their hearts. For that, I truly appreciate your help in teaching, and in particularly the areas where we really need to inform all the doctors and other medical professionals how to use drugs appropriately and to the benefit of the physicians. So to all those who participated, and not only the speakers and the moderators, but also people who helped us, like Mary Kelly, like Suzanne Buchauer, like Tyler Sandbar, and several others from the university. I cannot tell you how grateful I am for their kindness and giving us their wisdom. Thank you all. You are most appreciated.
And thank you, Dr. Sandbar. Just one more thing, 1492 for this session, 1492 for the CLE. And with that, we shall adjourn. Thank you. Safe travels.